Welcome. Thank you so much for everybody who was able to make it today. My name is Carl Oliver. I'm with the First Breath program here at the Wisconsin Women's Health Foundation. So thank you for joining us for today's webinar entitled Tobacco Use and Pregnancy in Wisconsin, reflecting on 20 plus years of data. For the sake of those watching the archived footage of today's presentation, I just wanted to be sure to mention that today's date is Wednesday, June 29th, 2016. The objectives for today's session are as follows. Attendees will learn of the demographic trends that exist around tobacco use and pregnancy here in Wisconsin. Attendees will learn about characteristics which correlate to higher rates of success with smoking cessation. And attendees will learn suggestions to apply this information into the care they provide through the First Breath program. So to help us address these objectives today, we actually have three outstanding guests joining us. We have Dr. Karen Palmersheim, an epidemiologist with the UW-Milwaukee Center for Urban Initiatives and Research. Karen will be sharing information from a recent report examining birth record data in Wisconsin from 1990 to 2013. Sarah Blackwell, an epidemiologist and PRAMS project director here in the state of Wisconsin. Sarah will be sharing PRAMS data from 2007 to 2013. And Kristine Alaniz, a program manager here at the Wisconsin Women's Health Foundation. Kristine will be sharing preliminary information from an ongoing project examining First Breath data from the last 10 years. So we're so thankful to be able to welcome these presenters to share information from these different sources, just to provide us with a more robust picture of the state of tobacco use and tobacco cessation among pregnant women here in Wisconsin. So we do actually have a lot of information to cover today. I'm hoping we still have time for questions at the end of our session. If you'd like to submit questions, please feel free to do so by using the GoToWebinar system. If we're not able to answer any of your questions during our time today, our speakers have generously offered to provide answers which we can send out via a follow-up email early next week. So leading things off, I'm now going to welcome Dr. Karen Palmersheim to take over the presentation.
Thank you, Carl. And I'd like to thank everybody out there for joining us today. We appreciate your attending our webinar. I'd also, before I get started reviewing the findings from my report, I'd like to thank the Wisconsin Tobacco Prevention and Control Program for their continuing support of the tobacco surveillance and evaluation work that we do for the state of Wisconsin. I'd also like to thank Chrissy and the First Breath program for inviting me to participate in this webinar, as well as earlier this year around Mother's Day, collaborating on a release of this report along with a press release. I think we got a lot of good information out there to the general public, and we also got a lot of good attention. So without further ado, I'm going to move forward and talk about the report a little bit. For some of you folks out there, I know that you have probably read the report or at least browsed through it, so some of this might be a little bit of a review for you. For others, I'm hoping that we can provide some new and useful information to you. So why is this such an important issue? Well, because pregnant women who smoke put themselves and their babies at risk for premature rupture of membranes, placenta previa, stillbirth, preterm delivery, and sudden infant death syndrome. We also have an increasing amount of evidence that smoking during pregnancy can be associated with certain birth defects, such as cleft lip or palate, as well as childhood asthma. And infants born to women who smoke are twice as likely to be low birth weight. And low birth weight is defined as being less than 2,500 grams at birth, which is equivalent to about 5.5 pounds. Looking at the data from Wisconsin for 2011 through 2013, I found that 11.4% of babies in Wisconsin who were born to women who smoked during pregnancy were classified as low birth weight. And that's in comparison to 6.4% of babies born to women who were not smoking. We also see that infants born to women who smoke are at an increased risk for infant mortality. And again, in Wisconsin, during 2011 through 2013, we experienced 9.5 deaths per 1,000 live births amongst babies born to women who smoked during pregnancy, compared to 5.4 deaths per 100 live births for non-smoking women. This figure shows us the overall prevalence of smoking during pregnancy in Wisconsin compared to the United States average over a 24-year period. As we go forward, what I'd like for people to do is I want to try to prevent us from getting bogged down in the numbers and statistics, but rather to look at the overall picture, and for each slide, maybe just take away one or two key points or concepts, because I think that's going to be the most useful as we move forward in trying to continue to reduce the prevalence of maternal smoking in Wisconsin. So as we look at this slide, we see that in the United States, the prevalence of smoking during pregnancy decreased from 8.4% in 1990 to 8.7% in 2013. During that same time period, in Wisconsin, we saw the prevalence of maternal smoking decrease from 22.9% in 1990 to 13.7% in 2013. I think what stands out in this figure, though, is that the majority of that decrease in smoking during pregnancy occurred between 1990 and approximately 2003 and 2005. And after that, it kind of levels off. So we actually had about almost a 40% relative decrease in maternal smoking during that first 2/3 of this timeline that we see, but then it kind of levels off. And it kind of hovers around 14% in Wisconsin. A good question that we need to ask ourselves is, why is this the case? And I'm not sure that we have a clear-cut answer. But what I would suggest is, as we move forward and look at some of the factors associated with smoking during pregnancy, is that we think about how those factors can lead us forward and help us to focus our resources on continuing to work on this important issue in the state. So this slide shows us the prevalence of smoking during pregnancy by the age of the mother. And even though we see this overall downward trend in the prevalence of smoking, what really stands out in this chart is that women in the two age groups, 18 to 19 and 20 to 24-year-old, are the most likely to smoke during pregnancy. If we were to break this down by age and race ethnicity, we would see some slightly different patterns for one particular group, and that's African American women. African American women tend to start smoking a little bit later in life, and so if you were to look at them by age, you would see that it's more the 20-year-old to 29-year-olds that are more likely to smoke during pregnancy. In this figure, we see the prevalence of smoking during pregnancy by race and ethnicity in Wisconsin. And what we see here is that for all of the groups except for one, the prevalence of smoking has gone down over this 24-year time period. And the other thing that really stands out is that the highest prevalence of smoking has been consistently amongst American Indian women in Wisconsin. We should note that while the prevalence of smoking amongst Asian Pacific Islander women, which predominantly in Wisconsin means the Hmong population, for that group, it has increased. It's still the lowest prevalence, but it is something that I think we should keep an eye on because it is increasing. In this slide, we see the prevalence of smoking by race and ethnicity in Wisconsin compared to the United States average. And what really stands out in this is that for Blacks, American Indians, Hispanics, and Asian women, the prevalence of maternal smoking in Wisconsin is double that what we see in the United States on average. In the past, when I've looked at this information, it basically has looked the same. So it appears that we haven't really made much change in this area. What I would point out, though, is for whites, it used to be a 1-to-1 ratio. And now it looks like in Wisconsin, even for white women, it is creeping above the national average. In this slide, we see the prevalence of smoking during pregnancy by educational attainment. And for me, what stands out is this impressive decrease in the prevalence of smoking in the first 2/3 of our timeline for those with less than a high school degree. However, we still have this persistent disparity by education, with women in the lowest level of educational attainment being more likely to smoke during pregnancy. And in fact, compared to women with a college degree, women with a high school degree and those with less than a high school degree were at least 14 times more likely to smoke during pregnancy. And women with some college were about 8 times more likely to smoke during pregnancy compared to those with a college education. Here we're taking a look at the prevalence of smoking during pregnancy by marital status, and we consistently see that women who are not married are much more likely to smoke compared to women who are married. And in fact, the disparity has increased over time. During 1990 to 92, unmarried women were about 2.5 times more likely to smoke during pregnancy than married women. When we get to 2011 to 2013, the difference is 4 times greater. And in this figure, we're taking a look at the prevalence of maternal smoking by trimester of prenatal care. Compared to women who initiated prenatal care during their first trimester of pregnancy, women who initiated care during the second or third trimester were nearly 1.5 times more likely to smoke. Women who did not receive prenatal care were more than twice as likely to smoke. In this figure, we're taking a look at the prevalence of smoking in Wisconsin by county. And if you take a look at the key down here, there's quite a bit of variation in the prevalence of maternal smoking across the state, ranging from 7.4% for Waukesha County all the way up to 34.8% for Iron County. And if you take a look at the map, you see there's a predominance of maternal smoking in the northern section of the state, as well as a handful of counties in the center of the state. So in summary, I would suggest that all women who smoke during their pregnancy, as well as before and after, should be considered for cessation intervention. But we really need to take a look at who is especially at increased risk. And from my findings, that would suggest we need to take a look at women in the age groups from 18 to 24, American Indian women, women with a high school degree or less, unmarried women. And unmarried women are actually, I would comment on this, are growing as a segment of the population. Most recently, the data shows that more than 1/3 of Wisconsin women giving birth are unmarried. It's actually about 37%. And we also should especially pay attention to women who do not receive prenatal care and those who initiate care later during their pregnancy. And finally, we need to strongly consider targeting women residing in the northern Wisconsin counties.
Thank you very much, Karen, for sharing that information. We're now going to be transitioning over to Sarah Blackwell with the PRAMS program and her slides.
Good afternoon, everyone. I'm Sarah Blackwell, and as Carl said, I'm the maternal and child health epidemiologist and the Pregnancy Risk Assessment Monitoring System Project Director with the Wisconsin Division of Public Health. And today I'm looking forward to sharing some recent data with you on perinatal smoking from the Pregnancy Risk Assessment Monitoring System, or PRAMS. And although PRAMS collects data on the demographic factors associated with perinatal smoking, I decided to focus today on data in PRAMS that will hopefully complement the vital records data presented by Dr. Palmersheim. So PRAMS is a male telephone survey that was first developed by the Centers for Disease Control and Prevention in 1987 in order to collect data that was complementary to the birth certificate in order to examine some of the maternal perceptions and experiences related to social environments, health conditions, behaviors, and healthcare that could help improve our understanding of the continued high rates of poor birth outcomes in the United States. And Wisconsin first received CDC funding for PRAMS in 2006, and we started data collection in 2007. And we currently select about 2,700 mothers each year from the live birth certificate to receive the survey. And we collaborate with the Wisconsin Partnership Program and the Life Course Initiative for Healthy Families to oversample non-Hispanic Black mothers in order to be able to examine racial and ethnic disparities in our social health and healthcare access risk factors for poor birth outcomes here in Wisconsin. And the information that we receive from mothers who respond to the survey are then weighted to be representative of all deliveries in the state. So the approximately 67,000 births we see in Wisconsin each year. PRAMS has been asking mothers about perinatal smoking since the development of the survey in 1987 and since the start of the survey here in Wisconsin in 2007. In the PRAMS Phase 7 questionnaire, which was the survey that we had in the field for 2012 and 2015 births, we asked mothers the following questions about smoking discussions with healthcare workers during prenatal care. During any of your prenatal care visits, did a doctor, nurse, or other healthcare worker talk with you about how smoking during pregnancy could affect your baby? We also asked mothers about their smoking habits before, during, and shortly after pregnancy with the following questions. Have you smoked any cigarettes in the past 2 years? In the 3 months before you got pregnant, how many cigarettes did you smoke on an average day? In the last 3 months of pregnancy, how many cigarettes did you smoke on an average day? And how many cigarettes do you smoke on an average day now? And we also ask questions related to secondhand smoke exposure for infants. Which of the following statements best describes the rules about smoking inside your home now, even if no one who lives in the home is a smoker? Using mothers' responses to these questions, we can look at smoking patterns and changes across the perinatal period, the tobacco use and screening that a mother may receive during pregnancy, and the potential exposure of the infant to secondhand smoke in the home. And we can also look at perinatal smoking data by the demographic and social factors that are in vital records and in the PRAMS data, as well as draw connections between perinatal smoking and other experiences and risks related to poor birth outcomes, such as perinatal traumas and stressors experienced by the mother and those close to her. Since we started collecting data in 2007, like on the birth certificate, we see that there hasn't been a marked or sustained improvement in perinatal smoking rates, with the prevalence of prenatal smoking hovering just under 30% and the prevalence of smoking in the last 3 months of pregnancy stagnating in the mid-teens. And as you can see in the lower line, the data are fairly comparable to what we see to that from the birth certificate, which was, I believe, Dr. Palmersheim said 13.7 in 2013 compared to the 16% we see in PRAMS. And for the rest of this presentation, I'm going to be focusing on the most recent 2 years of data that we have from PRAMS, which is 2012 and 2013, which were the first 2 years during which the Phase 7 version of the PRAMS survey was in the field. With the PRAMS data, we see many of the same differences across demographic groups that Dr. Palmersheim noted in the vital records data. Smoking before and during pregnancy in PRAMS was associated with maternal race and ethnicity, maternal age, maternal education, federal poverty level, as well as the type of insurance coverage that a mother reported having before pregnancy and to pay for her prenatal care. So what can PRAMS tell us beyond the demographics of the issue? Well, with regards to the prenatal care screening and health education, 3 out of 4 mothers reported having a healthcare worker talk to them about how smoking during pregnancy could affect their baby. And out of those who reported smoking in the 3 months before pregnancy, 85% reported having this discussion with a healthcare worker during prenatal care. Among the mothers who reported smoking in the 3 months prior to pregnancy, 37% reported reducing the number of cigarettes that they smoked during the last 3 months of their pregnancy versus before pregnancy, while 18% reported smoking the same amount or more, and 45% of mothers who smoked before pregnancy had quit by the last 3 months of pregnancy. And among those mothers that quit, 36% had resumed smoking by the time that they received the survey in the few months postpartum. And this slide is a little complicated, so bear with me. The pie chart on your left represents the smoking habits in the postpartum period among all mothers included in PRAMS. Over 80% of all mothers reported that they were a non-smoker during pregnancy and during the postpartum period. And an additional 1% reported smoking during pregnancy but quitting postpartum. And finally, 18% reported that they were smoking postpartum at the time of the survey. Mothers typically receive the survey 3 to 6 months after they've given birth. And so that question about are you smoking now can be somewhat variable related in time frame related to the birth by mother, depending on when she receives and when she responds to the survey. And so the pie on your right shows the breakdown of those 18% of mothers who reported that they were smoking postpartum. 12 of the 18% reported smoking the same amount or more than during pregnancy. 5 of the 18% reported having resumed smoking postpartum after quitting during pregnancy. And 1 of the 18% reported reducing the number of cigarettes in the postpartum period compared to during the last 3 months of pregnancy. One of the unique and important topics on which PRAMS collect data is perinatal stress and traumas that mothers and those close to them experience before and during pregnancy. Many people turn to or continue smoking as a means of coping with stress, and the perinatal period is a particularly stressful time that can potentially compound the financial, partner-related, traumatic, and emotional stress that can be part of daily life. Although the negative effects of smoking are well documented, and most women know that smoking can hurt them and their babies, some women, particularly those that are experiencing or have experienced substantial stress and trauma, find it difficult to give up smoking when they don't have other tools to cope with their experiences. Accordingly, in PRAMS, we see that smoking rates during pregnancy are higher among women who report experiencing perinatal stress and trauma. And so to look a little deeper into this, I looked at the association between different categories of stress and individual stressors within those categories and smoking during the last 3 months of pregnancy. So some of the stressors on which PRAMS collects data are grouped as financial stressors. Those are stressors such as partner losing their job, problems paying the bills, the mother losing her job, moving to a new address, or the mother or her partner having reduced worker pay. Among mothers who reported experiencing one or more of these financial stressors, the prevalence of smoking during pregnancy was nearly double the rate seen in mothers who did not report having financial stress. And smoking rates were significantly higher among mothers experiencing nearly every type of financial stress individually, except for those reporting that they or their partner had reduced worker pay. Partner-related stress in the year before birth, such as being separated or divorced from their partner, arguing more than usual with their partner, and the partner not desiring the pregnancy, was also significantly associated with smoking during pregnancy, with 26% of moms who experienced a partner-related stressor smoking during pregnancy, compared to only 11% of those who did not experience one of these stressors. And the greatest disparity is seen between those who reported having separated or divorced from their partner compared to those who did not experience that stressor. Mothers who reported arguing more with a partner were twice as likely to report smoking during pregnancy as those who did not experience that stressor. And although mothers who reported that their partners expressed that they did not want the pregnancy more often reported smoking during pregnancy than their counterparts, that individual partner-related stress was not significantly associated with smoking during pregnancy. And traumatic stressors, such as the respondent or their partner going to jail, experiencing homelessness, or having someone close struggling with a drinking or drug problem, showed the largest relative disparity in rates of smoking during pregnancy of any other category of stress. Nearly 40% of mothers who reported experiencing at least one of these stressors smoked in the last 3 months of pregnancy, compared to only 11% of mothers who did not have such stressors. And over 50% of mothers who reported that they or their partner went to jail in the year before the birth smoked during the last 3 months of pregnancy, 4 times the prevalence of mothers who did not experience this stress. Mothers who experienced the other 2 stressors were around 3 times more likely to report having smoked during the last 3 months of pregnancy than mothers who did not experience those stressors. In contrast to the 3 previous slides on financial, partner-related, and traumatic stressors, the emotional stressors that we collect in PRAMs, such as a family member being ill or someone very close to the respondent dying, these did not show a significant association with smoking during pregnancy in the PRAMs 2012 and 2013 data. And just to give a little context, the categorization of these stressors is something that's used nationally by the CDC when approaching the PRAMs data. And so there can be a little flexibility in these domains and a little overlap, but that's the reason why certain stressors were placed under those categories, if anyone was curious as to the logic. Sorry, there's a little just pop up on the screen. The webinar's reached the max. Okay, sorry about that. In addition to asking mothers about stressors that they experienced in the year before pregnancy, PRAMs also asked mothers about other stressful or traumatic experiences or conditions that might increase their stress level or decrease their ability to cope with that stress during the perinatal period, such as physical abuse by a current or former partner before and during pregnancy, depression prior to pregnancy, experience of racial discrimination, and not intending or being unsure of whether they intended the pregnancy. And rates of smoking during pregnancy were on the order of 2.3 to 3.4 times higher among those mothers who reported those experiences and conditions than those who did not. And you can see the differences by individual stressors there. And stress is not the only reason for stagnating rates of smoking during pregnancy in Wisconsin. And it was just what I chose to highlight today as a complement to what's available on the birth certificate. So after this presentation, if anyone is interested in looking at perinatal smoking by any of the other life course or perinatal risk factors that we collect in PRAMs, please don't hesitate to contact me, and I'd be really happy to look at those data for you. And although the focus of this presentation was a detailed look at that perinatal stress and smoking habits during pregnancy connection, I also wanted to make sure to share with you PRAMs data on smoking rules inside the home after the birth of the baby, since this is data we collect and data that hasn't often been communicated. So during 2012 through 2013, 95% of all mothers reported that smoking is not allowed anywhere in the home, and fewer than 1 in 100 of all mothers reported that smoking was permitted anywhere in the home with no restrictions. And mothers who were current smokers at the time of pregnancy, at the time of the survey, were more likely to allow smoking in some rooms or at some times, with a combined 17% reporting that either limited or unrestricted smoking was allowed in the home. Okay, so thank you for the opportunity to share this data with you today, and I'd be happy after the following presentations to answer any questions that you may have about the data that I presented here or about the PRAM survey in general and looking at perinatal smoking by any of the other factors that we collect. And I'd like to acknowledge the CDC for providing funding for the core operation of PRAMs, the Title V Maternal and Child Health Block Grant Program for providing supplemental funding, and the Wisconsin Partnership Program and the Life Course Initiative for Healthy Families for providing funding for the non-Hispanic Black oversample in PRAMs. Thank you.
Thank you, Sarah. So if everybody could bear with us for a brief moment of technological struggle, we're going to be transitioning our presentation over to Kristine, who's currently off-site. So bear with us for just a moment here. Chrissy, can you hear us? Are you with us?
I am here. Can you hear me?
Yes, we can. Thank you.
Okay, and you can see the screen?
Yes, I believe we're good.
All right, great. Thanks, Carl. And also thank you to Dr. Palmersheim and to Sarah, too. I am just thrilled to be part of this presentation today. And I'm going to keep the momentum going, but I'm going to change the focus a little bit. And instead of looking at population-based data, we're going to focus in on specifically the first breath participants over the last 10 years. Just keep in mind this is a little bit of a different subset because these women chose to participate in a quit smoking program, so they're at least somewhat receptive to change or to at least the information, and they're also receiving prenatal care. So just keep that in mind as we go through today. Here at the Wisconsin Women's Health Foundation, we are actually celebrating First Breath's 15th anniversary, and we've taken on the task of looking at a larger data set of our participants, knowing that the maternal smoking rates have stalled these last few years, and to kind of reflect on the past and look at the future. We wanted to look for trends and identify some areas for improvement within the program. And so we have this great set of 10 years worth of data, and I'm going to share some of the preliminary results with you today. So first, just a quick background, and I'm going to keep this short and sweet because I know we have a lot of First Breath providers on the line who are intimately familiar with the program. Some of you have probably been with us the entire 15 years, so just bear with me. But First Breath started as a pilot in 2001, so this is our 15th anniversary. First Breath is a brief intervention that's integrated into existing prenatal care. We currently have about 170 sites, and those are organizations where First Breath is implemented, and those are WIC departments, health departments, PNCC programs, OB clinics, you name it. Wherever pregnant women are, we are too. And at those sites, we have over 1,000 providers that are currently trained to do the First Breath brief intervention. We're also operating in 63 of the 72 counties in Wisconsin, and of course our goal has always been to be in every county, so we're getting close. And our enrollment to date is approaching 18,000 women. So just some quick information on how and when we collect data for First Breath. We have 3 surveys, and our First Breath providers complete these surveys with their patients and submit to us at the Wisconsin Women's Health Foundation. We have a baseline or enrollment survey that typically happens in early pregnancy, but can be later too. If the patient initiates care later on in the pregnancy, we'll still do a baseline then. We have a prenatal follow-up, which is typically late pregnancy, and a postpartum follow-up survey, which is somewhere around 6 weeks postpartum. And through these 3 surveys, we collect demographic data, smoking behavior data, and other health-related data, questions like stress, mood, social support, and quit importance. So getting to the need for the 10-year analysis, basically, Dr. Palmersheim and Sarah already touched on this, but there's been a real stall in maternal smoking rates here in Wisconsin. And since the First Breath program is now well established, we wanted to see where we've come and see where we need to go moving forward. We've collected data since the very beginning of First Breath, and every year we look at our annual data set, which is about 1,000 to 1,500 women. We analyze these sets, and then we share with our providers and our partners. But again, like I said, because we're celebrating 15 years, we wanted to look at the bigger picture instead of looking at multi-year data sets. And we were actually able to extract 10 years worth of data, 2000 to 2015, that included over 11,000 pregnancies or enrollments. Many of the results that I'm going to show with you are based on smaller subsets, anywhere from 1,000 to 8,000 women, due to missing data, which I'll explain shortly. And today I'm going to share just some kind of the tip of the iceberg. We have a lot of information, a lot of results, but I want to focus in on 3 areas. The first is just participant demographics and some basic outcomes regarding their smoking behavior changes during their involvement in the program. We're also going to look at differences in smoking amounts based on participant characteristics, and I'll spend more time on that. And lastly, the implications. What does this mean for us as providers and the First Breath program? And of course, you can't talk about data without talking about the limitations. Old data comes from old computers and old programs. We actually had to merge 2 pretty huge databases, one very old, which was a challenge. We also have some data inconsistency over the year. Fortunately, most of the core questions about smoking outcome data have been consistent throughout, but some of the supplemental questions have changed. The Tobacco Prevention and Control Program has been our main funder over the years, but we've also received smaller supplemental grants. And often with those, we're required to ask different questions or ask in a different way. So as a result, we have some missing data, or we have just different data that's hard to compare. The other big limitation is that we have a high loss to follow-up rate, which we have been grappling with for years. Women enroll at pretty high rates. A lot of them complete that second survey, but by postpartum, we've lost them. And a lot of times it's just that women don't show up for their postpartum visit, but there's some other issues as well. So whenever we're missing postpartum data, it means we can't do full outcome data. So that's an obvious limitation. And then, of course, it's self-report. So we'll jump in with part one, just to give you an idea of who enrolled in the program. And I'll also share some of the smoking outcomes for those that completed the program, meaning they did that postpartum survey. And just keep in mind, this is 10 years worth of data, and this is also statewide. So I think it'll be interesting to all of the providers on the line to compare the overall statewide numbers to your own site and own patients and see how they compare. I'm going to start with the basic baseline smoking status. So this is where women are smoking when they enroll in the program. A very small percentage, less than 1%, have recently quit and were not smoking at all at baseline. That probably means that the women who quit right away, the suspended quitters as we call them, they quit and they stay quit through the pregnancy, they're probably not enrolling in first breath. We had a few intermittent smokers, meaning they smoked here or there, but not daily. And then on both ends, we had small groups of very light smokers, meaning 1 to 5 cigarettes per day, and very heavy smokers who were smoking 1 to 2 or even more packs per day. And the majority fell into this moderate smoking category. They smoked around half a pack, some slightly less, 6 to 10 cigarettes per day, and some slightly more, 11 to 20. So I'll be curious to hear how this overall data set compares to your own site. Next, taking a quick peek at age of enrollment. Not surprisingly, because all of our participants are pregnant, most are in their 20s and early 30s. Our youngest enrollees were in their early teens, and the oldest were in mid to late 40s. So we had a fair amount of age diversity overall, and I believe this varies quite a bit by individual sites too. Some sites see mostly teen moms, and others see majority older women. Next, we're looking at race and ethnicity of those that enrolled. We are mostly white women and African Americans, 70 and 20%. We have small percentages of American Indian, Asian, and women who identified as bi or multiracial. 6% of participants were of Hispanic ethnicity, the rest were non-Hispanic. And at first looking at this, I was a little bit concerned about a lack of diversity among our participants, but looking at Wisconsin demographics is actually on trend. So just keep in mind that these numbers reflect the entire state. Looking at educational attainment, most women were either high school or GED graduates or had some college education. Smaller percentages had less than high school, diploma, or a college diploma and beyond. And then insurance type, the overwhelming majority, almost 80%, were Medicaid. And that's, I'm going to stop right there with the demographics. We have a lot more, but I didn't want to include everything. I'd rather focus on some of the good stuff. So, oops, sorry about that. So looking at overall smoking outcomes. So remember, we had over 11,000 women who completed that enrollment survey, and around half completed a postpartum survey, around 5,800. And of those, 84% made a positive change, 34% quit, and for that small percentage of women who were not smoking at baseline, they quit, and 49% cut down on their smoking throughout their pregnancies. So we're very satisfied with our outcome data overall these last 10 years, and of course, we have our amazing providers, some of who are pictured here for these impressive numbers. We want to go a little bit deeper than just looking at the smoking outcomes. We know more about the size and the makeup of this group, but I want to spend most of our time here looking at differences in smoking amounts throughout the perinatal period. So we'll start by looking at one of the major trends we identified, and that is the variation in smoking amounts. I'm going to touch on this just briefly. The first column, looking down right here, you can see baseline smoking amount. We have intermittent smokers, we have the very light smokers, we have our moderate smokers, and our very heavy smokers. And if you look at the quit rate, right here, you'll see that lighter smokers have higher quit rates, and there's a really huge jump right there. And that, makes some sense. Maybe they're less dependent on nicotine, either physically or the habitual smoking, but the variation is just really huge. And then when you look at cut down rate and overall positive change, you'll see the inverse. So heavier smokers did better at cutting down and at overall positive change. And overall, I mean that we combine the quit and the cut down. So that's pretty interesting. That's just to give you a little teaser to show you the variation among different subsets of women. And now we're going to go a little bit deeper. Our main question for this section was, are women smoking significantly more based on any of these factors? Age, race, education, insurance, stress level, smoking history or quit importance. And we're looking at 3 different time periods: early pregnancy, late pregnancy, and postpartum. So the short answer to our question is yes, there were significant differences, but not exactly what we would have predicted. So, oops, sorry. Keeps jumping ahead on me. There we go. All right, looking first at early pregnancy, and we looked at all of the 7 factors from that previous slide, and we found that 2 had differences in smoking amounts. The first was stress. So women with medium to high stress levels smoked significantly more than those with low stress levels. And the other was smoking history. So during early pregnancy, women who smoked for 11 to 15 years smoked significantly more than those who only smoked 6 to 10 years. And we'll discuss the possible reasons for this in a bit, but first we're going to look at the other time periods. Now we're looking later in pregnancy, and of the 7 factors we looked at, 4 had significant differences in smoking amounts. We had years smoked again, so women with longer smoking history smoked more than those with shorter history. And next was relationship status. We found that women in a relationship smoked significantly more than those who were single. So this is interesting because if you remember Karen's report, just looking at smoking prevalence, single women tended to smoke at higher rates. But looking at smoking amounts, it's a different story. So the women in relationships smoked a lot more than those who were single on all accounts. The third was quit importance. So women who reported that quitting or staying quit was not important, smoked more than those who said it was important. And then finally, race. So at the end of pregnancy, white women smoked significantly more than Black women. And again, we'll discuss these possible reasons why in just a minute. Finally, we're going to look at the postpartum period. We have the same 3 factors that come up again: stress, lower quit importance, and longer smoking history. They all smoked significantly more than women with low stress, higher quit importance, and a shorter smoking history. We're going to shift now. Instead of a single time period, we're going to look at how participants made behavior changes over time during the pregnancy. So here we're comparing the smoking amounts between early and late pregnancy. And we're looking at positive change. So which women made the most progress in terms of reducing their smoking amounts from baseline to late pregnancy? And of all those factors that we looked at, age was the only one that had significant differences. Younger women had significantly greater positive change and made more progress than older women. And it was incremental too, so women less than 18 years old had much more change than those with 19 to 26 years old. And 19 to 26 had significantly greater positive change than the older women. The other behavior change we measured was postpartum relapse, so women who quit during pregnancy and then smoked again postpartum. And what's interesting is those younger women from the previous slide, under 18, who made the most positive change to their prenatal smoking habits, unfortunately relapsed higher than any other age group. And also those same 3 factors again, higher stress, low quit importance, and longer smoking history all relapsed at significantly higher rates. And the one item that just doesn't fit the trend is the last point. Women with very short smoking history, meaning they've only been smoking for 0 to 5 years, relapsed at higher rates than those that smoked 16 to 18 years. So putting these all together, what does this all mean? We just wanted to offer a few possible explanations, and we would obviously love your feedback and additional ideas and reactions to these results as well. So I think it really makes, affects the implications for our program and our intervention. So starting with higher stress, which is the one that came up a lot, it's the #1 reason we hear, and I'm certain that you do too, that smoking is used as a coping mechanism for stress. And someone experiencing very high levels of stress, be it violence, homelessness, incarceration, financial difficulty, quitting may just be less of a priority. Looking next at smoking history, at the outset, this one's easy to explain too. More years smoked means more years of physical addiction to nicotine. They have more nicotine receptors. It's more ingrained into their daily life and habits and potentially their support network. But that last slide where we looked at the women who smoked less than 5 years relapsing at significantly higher rate, that turns it on its head a little bit. So this is something we need to explore further and deeper. Perhaps it's related to age, but perhaps there's something else there too. Also looking at lower quit importance. So women who report low quit importance may be less invested in the program. They may be less likely to take steps to quit on their own. Perhaps they're less receptive or less likely to follow guidance from their first breath provider, or they may just be focused on short-term behavior change. These are the women that are willing to quit or cut down during pregnancy, but then within hours or minutes of giving birth, they're back to smoking again. Sorry about that. So looking at age, again, is it related to your smoking? It may be for younger women, quitting smoking is less of a priority or lower perceived risk. Or maybe, again, are they less receptive to change or guidance from a provider? That would be something I would be interested in hearing from all of you in the audience. And then lastly, the relationship conundrum. Is it connected to age and years smoked again? Or perhaps the partner is a smoker, or the partner is their smoking trigger or a major cause of life stress? We have theory, but there still remains a lot of unanswered questions. And again, we would love your feedback and ideas on this. Some of the notable missing factors, if you remember from that first slide, there were 7 things we looked at, and there were some that didn't come up at all, which I found very interesting. Rates only came up once, just in late pregnancy, and not at all with behavior change. Also, education and insurance status were also missing. So the lack of significant differences in these groups is something we want to explore too. The easiest explanation is that addiction is addiction. It doesn't matter if you're white, black, educated, on Medicaid. But while there might be a greater truth to that, we think it goes a lot deeper than that too. And again, we'd love to hear from you on that. So we're left with a lot more questions and areas to explore further, but that is definitely a good thing. We absolutely want our program participants to succeed, and we want to ensure that you as providers have the most effective tools to counsel your patients. And so the biggest takeaway that we have, just looking at the preliminary data, is that we want to do a better job tailoring interventions, especially for those that are at greater risk of continued prenatal smoking, heavy smoking, or relapse. A first step that we've taken is pictured here. This spring, we conducted a large qualitative study with a sub-study of our 5-year Medicaid-funded Striving to Quit research grant. We conducted focus groups and in-depth individual interviews with about 150 of our program participants. And the participants were incredibly engaged, and they had a lot of great feedback for us. And we'll share those results at our regional sharing sessions this October. And as a branch out from the focus groups, we're starting participant advisory groups. So we hope that these groups will guide our program from patient ed materials to services to incentives. So if you as providers have any first breath graduates, folks that have already gone through the program that you're still in contact with, who you think might be interested in the group, please let me know. It's a great resume builder for them and obviously a valuable source of information for us. And then looking more broadly, this circles back to Dr. Palmersheim and Sarah's presentation, is that our maternal smoking rate has fell. So we see a lot of success in our program participants, but we want to be able to reach more women. Right now we're seeing 1,000 to 1,500 women, pregnant smokers a year, but we know that in our state about 9,000 women smoke during our pregnancy. So we've all got our thinking caps on and hope to talk with you more too to find out how we can have more of an impact on those maternal and enroll more women into the program. In terms of data-related next steps, we're going to continue to work with you, our providers, to make data collection process as painless as humanly possible. Many of you have jumped on the electronic survey bandwagon, and I encourage everyone to consider this option. We're also open to other suggestions, too, to ensure that we have clean and complete data. And we're also developing systems reminders to reduce that loss of follow-up rate so that we can get more postpartum service. In terms of the 10-year analysis, we'd like to run some more advanced tests. We want to control for age and smoking history so that we can really key in on some of those most influential factors that lead to higher smoking rates and relapse rates. And then later this year, we'll publish a white paper of the major findings, so stay tuned for that as well. I'm going to stop there. Just real quickly, I wanted to show you that in our presentation, we had a lot of photos of our participants, and these are all women that shared their testimonials with us, either written or video testimonials. So if you wanted to check any of those out, we have about 30 of them on our YouTube channel, so you can check them out. They're all very brave women with powerful stories, so I'd encourage you to take a look and share with your participants as well. And I will stop right there.
Thank you very much, Chrissy. Thanks for sharing that information. Now we do have a few questions that had come in. I know there was actually quite a few people who had requested copies of the slides. Those will be sent out. They'll be sent out, I would think, later this week or early next week. So just a heads up that that is something that's coming up. One other thing that I guess just kind of a couple questions that I'll pose to the group as a whole. Certainly, I know your background backgrounds are pretty much all in data. So I understand not wanting to kind of throw out anything willy-nilly. But I know one of the questions that did come up is, as you had both mentioned, the rates of tobacco use during pregnancy were declining for years, and then they had kind of leveled off or seemed to kind of hit a bit of a plateau. I guess any theory from our presenters, or I guess not even theory of why this is, but is this a Wisconsin-specific phenomena? Is there similar data nationwide of kind of these rates leveling off? Just feel free to speak up.
This is Karen Palmersheim. I guess I have a couple of thoughts on that. Of course, we don't know for sure. We really don't have the data to clearly tease that out. So all we can really do is hypothesize by looking at the rest of the information that we have. And one of the things I would say is that even when we look at overall adult prevalence of smoking in Wisconsin, while it is going down, it had really leveled off for quite a period where we were only seeing maybe a 0.5 percentage point decrease per year, even though Wisconsin has actually been pretty good in the efforts that we have put forth in trying to reduce tobacco use in the state. So I think, and I think Chrissy touched on this too, in terms of looking in, when you're digging deeper into the subsample of all births in Wisconsin, where you saw the opposite of what I saw with like marital relationships and relationships in general, I think you have to look at the person's overall social environment. And so if you look at the prevalence of smoking in the overall adult population in the state of Wisconsin and see how slowly it is going down, I think that's a testament to, that's kind of testimony to how difficult it is to get maybe that final subsection of the population to quit smoking. It's also interesting to look at that map of the Wisconsin counties, where we see the northern 1/3 of the state in particular having a higher prevalence of maternal smoking. We see similar counties with a higher prevalence of overall adult smoking. So again, that social environment is really important. The social norms that go along with any subsection of the population, I think, are really a strong driving force to smoking behavior.
And I would agree with Dr. Palmersheim that I think, well, first to preface, I am a maternal and child health generalist and more like an expert in PRAMS data versus perinatal smoking data in PRAMS. So like, I lean on everyone who's, I'm sure, in the audience today as the experts who can help contextualize these data more fully to help understand the continued problem. But as with many MCH issues that we are really struggling to improve and move the needle on, one of my hunches would be that it is those social determinants that are so hard to change that help predict the need for coping strategies such as smoking. So adverse childhood experiences and perinatal stresses and traumas like I presented today, but also coupled with a lot of those factors in the social environment that could inhibit women from stopping smoking during pregnancy.
Mm-hmm. Excellent. Chrissy, was there anything you wanted to add on that question?
No, I think they both did a great job explaining, and I would just echo the social environment and the social norms. In our Striving to Quit research study, and especially in our focus groups and our kind of qualitative analysis, I just can't even tell you how often that comes up, that they're trying their best to quit, but they live in a household where 4 other people smoke, the father of the baby smokes. It is really hard to quit, and even if you do, it's then really easy to relapse when you're in that environment. So I think that's something that the Wisconsin Women's Health Foundation is starting to explore this year, is looking more at the family-based intervention versus just the woman, because we know that when you're in that environment where it's just so normal to smoke, everyone smokes, your entire family, your neighbors, you can't make much progress. So, yeah.
Excellent. Thank you. One more question. This one's a little bit more directed towards Sarah, but certainly anyone can contribute. You had mentioned or shared data that a lot of different types of stress will correlate with higher rates of tobacco use during pregnancy. Did you have any way to account for overlapping stressors? It seems like a lot of the clients that, at least that we're working with through First Breath, they aren't just dealing with one or two stressors, they're dealing with 5 to 6.
Yeah, that is something we look at too that I didn't include in this presentation, but we look at the cumulative stressors that a woman experiences and look at the number and burden of those stresses and the outcomes. I haven't looked at that particularly with regards to perinatal smoking yet, but I would be happy to do that, especially if there are particular stressors that people would like to see grouped or would like to see somewhat disentangled to see what independent effects of those stressors are. I'd be very happy to look at that if people are interested. So feel free to contact me about that.
Gotcha. Excellent. And then one other question that did come up. Karen, you had shared some data that showed an increased rate of smoking for women who are not receiving prenatal care. And again, I understand you guys work in the data world, so this might not be a perfect question for you, but sometimes it's good to ask people outside the box. Do you have any suggestions? Because sometimes it's difficult to help a woman who's not receiving prenatal care quit smoking because she's not receiving prenatal care. Any suggestions for how to better reach these women?
That's a really good question. First of all, we have seen a decrease in the prevalence of maternal smoking, even amongst women with no prenatal care, if we look at that overall 24-year period. So that's a big chunk of time. So the good news is it has decreased for that subgroup of that population. However, I think, getting the message out there that there is prenatal care available for all women, to my knowledge, and Chrissy may be better able to, answer this question, but to my knowledge, even if you do not have health insurance, if you fall into a Medicaid program, I believe there is prenatal care. And perhaps it's getting that information out there to those women and helping them to get into the system and to receive prenatal care. I think that is probably the toughest group to reach, no doubt, because they're not coming in to see a provider. So how can you even talk to them about maternal smoking and how it impacts themselves and their babies? So I think we need to just get that message out there somehow that that care is available for even women who feel they can't afford it.
And I would just say, although there's clear multifaceted benefits for getting all women into prenatal care, not just related to smoking cessation, there are potentially opportunities if women don't seek that access to care for reasons other than the fact that they lack access through health insurance, then maybe trying to reach or better broadcast the opportunities to get referrals to services that aren't necessarily through prenatal care, such as the First Breath program, through the MCH hotline, through the Quit line, and possibly getting health education messages and referrals to programs through Text for Baby and things like that can provide that conduit to services that aren't necessarily within the prenatal care sphere, but we might have opportunities for collaboration, such as through WIC clinics or with that the Text for Baby program.
Excellent. Chrissy, did you want to weigh in on this question as well?
Yeah, to me, that it just makes the case for community-based outreach and sort of the non-traditional partnerships that what they're listening to. Right now, First Breath is operating exclusively through programs that see pregnant women, so they're actually able to come to their appointments, they're getting out and receiving that care. So to me, it just makes the case that we need to put a little bit more action and funding behind that community-based outreach, whether it's commercials or word of mouth or street outreach, to reach those women who probably need the help more than anyone, not just with smoking, but with other services as well.
Excellent. Thank you very much, Chrissy. The one other thing I was just going to contribute on that question, after meeting with a lot of our First Breath providers over the last few years, is just never overestimating or never underestimating the power that personal relationship you're forming with your clients has. If you're working with a pregnant woman, odds are she knows other pregnant women, and that referral is going to mean a lot more. It's going to carry a lot more weight if she talks to her friend and says, "Oh, you should really meet with XYZ. I went there. It went really well. I'm really glad that I went there. So just realizing that as you're ending those relationships with a client because she's transitioning into some other kind of care, realizing that she can be a fantastic conduit for other women to be able to find you. And I know that does bring us up to just after 2 o'clock now, and I don't want to take up more time than I have to. So I just wanted to say thank you so much to our presenters today. We really appreciated that you were able to join us. You were able to share this fantastic information. For anybody who did have questions that we were not able to address, I know there were just a couple more. Please just be aware we'll probably be sending out responses to those in a follow-up email. So yeah, once again, thank you everybody for joining us. Yeah, and I hope you have a great afternoon.